Hi all, welcome back to the emergency medicine lecture series. After some gap, I'm decided to redo the videos again. Today we are going to discuss about a very small topic, often a neglected topic, which is very important in critical care and sometimes in the emergency medicine department also. That is the abdominal compartment syndrome. You all know that a compartment syndrome occurs when the pressure within a compartment, which is bounded by the muscles and the facial planes, exceeds the normal pressure in the compartment. The increased pressure can lead to decreased perfusion. Decreased perfusion can lead to muscle necrosis and things. When it is coming to the intra-abdominal hypertension, the normal abdominal pressure should be less than 12 millimeters of mercury. Whenever there is a sustained rise of abdominal pressure of more than 12 millimeters of mercury, it is termed as intra-abdominal hypertension. When this intra-abdominal pressure exceeds repeatedly above 20 millimeters of mercury, it has the potential to cause end organ damage or the organ dysfunction. The presence of organ dysfunction and increased abdominal pressure, which confirms the abdominal compartment syndrome. There should be a high clinical suspicion with protocolized monitoring and management for effective management of abdominal compartment syndrome and almost all the critically ill patients, especially if they are on ventilator. Etiology can be either primary, secondary, or chronic. Primary means you all know that there is a problem within the abdomen. Secondary, problems within the abdomen but not exactly related to a pathological state. When it comes to the primary, the causes include abdominal trauma, most commonly blunt abdominal trauma, which can lead to fluid. The inflammation and the swelling that is caused increases the intra-abdominal contents. The abdominal wall compliance is reduced and the abdominal wall cannot expand. The pressure starts rising. Intra-abdominal hemorrhage has a similar effect. Rupture of aortic aneurysm, rupture of AAA is one of the most important causes of primary abdominal compartment syndrome. Intestinal obstruction, the intestine is filled with the bowel and feces and also the gas, which can lead to increased pressure within the abdomen, or retroperitoneal hematoma can lead to. These are the primary causes. Come to secondary causes, they're not directly related to the abdominal pathology, like pregnancy, tense ascites, paralytic ileus, burns, intra-abdominal sepsis, large volume fluid registration in a patient who has sepsis, where there are leaky capillaries, can lead to extravasation of fluid, third spacing of fluid into the compartments. When it occurs in the abdomen, it leads to secondary abdominal compartment syndrome. Usually a fluid amount of greater than 3 liters is required for it to cause ACS. High peak airway pressure. This pressure can lead to air entering into the gastrointestinal system, leading to dilation of the stomach, which can lead to increased intra-abdominal pressure. Inadequate ventilation and oxygenation, which increase inflammation, can also be the causes for secondary abdominal compartment syndrome. When it comes to the chronic causes, usually it's pregnancy, cirrhosis of liver with increasing ascites, obesity, where the abdominal wall compliance due to fat storage, lot of fat storage in the abdominal wall compliance is reduced, and these patients are prone for chronic ACS. Intra-abdominal malignancy and peritoneal dialysis similarly affect the abdomen. Risk factors that you need to keep in mind include a reduced abdominal compliance, increase in the intra-abdominal contents like in hemorrhage or intestinal obstruction, increase in luminal contents or third space expansion within the abdomen, and also increased capillary leak. There are 4 grades when it comes to intra-abdominal hypertension. Grade 1 and grade 2, there will not be any organ dysfunction, or there can be only mild organ dysfunction. Grade 1, intra-abdominal pressure is 12 to 15 millimeters of mercury. Remember, less than 12 is the normal. 12 to 15 is grade 1, 16 to 20 is grade 2, 21 to 25 is grade 3, and IAP greater than 25 millimeters of mercury is grade 4. Grade 4 is the most common cause for organ dysfunction. Let's have a look at the pathophysiology. As I told earlier, increased contents either in the peritoneum or within the bowel loops is the most common cause of intra-abdominal compartment syndrome. Organs typically affected include heart, lungs, and the kidneys. The cardiac sequelae are because of decreased cardiac output and increased central venous pressure as a result of pressure on the inferior vena cava, which reduces venous return. And there is also portal vein compression, which again reduces free flow of portal blood, and there is stasis within the abdominal compartment, and that leads to extravasation. Increase in systemic vascular resistance, which further leads to hypotension. Pulmonary involvement includes decreased thoracic volumes and elevated peak pressures from compression of the diaphragm, a decrease in P by F ratio, and hypercarbia will ensue eventually. There is compression of the renal vasculature and the renal medullary. This leads to decreased GFR and low urine output. Whenever you find sepsis patients with reduced GFR or patient going into AKI, one of the most important differential diagnosis you need to look for and treat is ACS. Neurologic symptoms can include increased intracranial pressure from the elevated CVP due to IVC compression. Coming to history and physical examination, is diagnosis typically made in the ICU setup. Most commonly, it's not a diagnosis in the ED, even in the critical patients. But the importance for an emergency physician is when a post-operative patient presents to you with increased abdominal girth and abdominal pain, or a penetrating abdominal trauma patient, or surgical patients following extended abdominal surgery are presented with a second episode of abdominal pain with abdominal distension, you should strongly suspect abdominal compartment syndrome. As I told, the presenting features include abdominal pain and distension. Physical examination may reveal increased abdominal girth. There can be a tense abdomen, cyanosis, wheezing, and difficulty breathing, increase in workout breathing, all due to reduced thoracic pressure due to pushing above the diaphragm. There can be ventilation and perfusion mismatching, again due to reduced intrathoracic volume. Increase in both peak and flat tube pressures is noted in ventilated patients. Coming to the evaluation of abdominal compartment syndrome, imaging cannot diagnose the pressures, but imaging is useful in detecting the cause of ACS like intra-abdominal bleeding, intestinal obstruction, or a solid organ injury. Erect X-ray abdomen can detect intestinal obstruction and a perforated hollow viscus where there is extravasation of components. USG abdomen can definitively diagnose intestinal obstruction and can qualify. CECT abdomen is the most common diagnosis. Apart from giving you a clue on the diagnosis, it can also give you clue on how much the IVC compression is there and how much is it can quantify the hemorrhage actually. Ultrasound abdomen can also give you IVC compression or IVC dilation. Definitive diagnosis of abdominal is by measurement of abdominal compartment pressure. Abdominal compartment pressure is usually measured when any known risk of intra-abdominal hypertension is present, like the risk factors I told earlier. Coming to the measurement of abdominal pressure, it can be either measured directly or indirectly. Direct methods usually include the pressure transducers like Veress needle during laparoscopic surgery or intraperitoneal catheters placed transcutaneously, or a peritoneal dialysis catheter can be used. These direct methods are usually most accurate, but invasiveness of these procedures limits their value. Most commonly used and the gold standard method is the indirect methods. Non-invasiveness of this procedure made it a gold standard now. Usually it is measured using intravesical pressures through a Foley's catheter. Bladder pressures below 5 millimeters of mercury are considered as normal. Pressures between 10 to 15 millimeters of mercury can be expected following an abdominal surgery, especially in obese patients. Bladder pressures over 25 millimeters of mercury are highly suspicious of compartment syndrome. In this slide, I have given you a schematic view how the intra-abdominal pressure is monitored. You pass a Foley's catheter under aseptic precautions, and at the beginning of the Foley's catheter, you connect a three-way valve, and the catheter is clamped aseptically. And then you connect this to a pressure transducer and a sterile saline solution. Once it is clamped, you inject 25 cc of saline into the bladder, and the pressure is measured either through a sphygmomanometer connected here or the transducer connected to the multiparameter, which can detect the pressure. Just like how you measure your intra-arterial pressure, you can measure intravesical pressure using a Foley's catheter. Coming to the differential diagnosis of abdominal compartment syndrome, most common mesenteric ischemia. Patient presents similarly with abdominal distension and abdominal pain. Pain will be disproportionate to the clinical findings that you have. A ruptured abdominal aortic aneurysm, toxic megacolon, acute appendicitis, acute diverticulitis, all these conditions again in turn can cause acute abdominal compartment syndrome. Treatment, there are two options: non-surgical therapeutic in the initial stages. Definitive management is by surgical decompression, emergency laparotomy. Non-surgical therapeutic options include improvement of abdominal wall compliance with a decreased muscle contraction. It is achieved usually by benzodiazepine drugs and also temporarily muscle relaxants in patients who are mechanically ventilated. Evacuation of luminal contents by decompression, usually by nasogastric tube. Evacuation of abdominal fluid by rectal drainage. Correction of positive fluid balance through goal direct to volume registration. Evacuation of ascites through transcutaneous routes are the non-therapeutic options. Surgical decompression is usually done by surgical laparotomy. After surgical laparotomy for compartment syndrome, the abdominal fascia may be closed using temporary closure devices like clips or suturing. Post-operative and rehabilitative care. After decompression of the abdomen, many patients will still require the following modalities like fluid restriction, diuretics to improve renal function, early ambulation, and deep venous thrombosis prophylaxis. Clinical perils of today's video. Intra-abdominal hypertension is diagnosed by sustained or repeated elevation of IAP more than 12 millimeters of mercury. Abdominal compartment syndrome is diagnosed when intra-abdominal pressure is more than 20 millimeters of mercury sustained and is associated with organ dysfunction or failure. IAH grade 1, 12 to 15 millimeters of mercury. Grade 2 is 16 to 20 millimeters of mercury. Grade 3 is 21 to 25 millimeters of mercury. Grade 4 is IAP greater than 25 millimeters of mercury. A trial of neuromuscular blockade can be used to alleviate compressive symptoms in ACS while awaiting surgical decompression. Thank you. Don't forget to subscribe and share the videos for wider dissemination. Thank you once again.